Professor Upendra Devkota, our respected teacher, so I'm proud to be his student while I was in NAMS, the first qualified neurosurgeon of the country who established the modern neurosurgery in the country, passed away on 2075, 4th Asar, Monday at 5:30 p.m. It's been already 26 days. Professor Devkota was born in 2010, 094 BS on Friday in Gorkha. He became the first qualified neurosurgeon of the country in 1989 and served the nation and Nepalese population and people tirelessly. In this moment of deep sorrow, the SSN Executive Committee, along with all of the SSN family, mourns and pay homage to late Professor Devkota. May his soul, may the soul of our respectful teacher reside in eternal peace. SSN also expresses a deep condolences to the bereaved family and prays for their patience and power to cope up with this sad situation. Professor Devkota has always been the integral part of SSN, delivering his insight in each and every conference of SSN, and it was always a charm to listen to him. So these are the few photographs I would like to share where he delivered a lecture on the evidence-based medical practice. Society of Surgeons of Nepal proudly acknowledges Professor Devkota for his outstanding pioneer contribution to the field of neurosurgery in Nepal and for the leadership and dedication for promotion of surgical education and the services to the nation. So, ladies and gentlemen, I humbly request you to stand up and observe 1 minute of silence to pay tribute to this great man. Thank you very much. So lastly, to conclude with, I want to quote his saying, जीवन आमाको गर्भबाट चिहान सम्मको यात्रा हो, मृत्यु नै जीवनको अन्तिम सत्य हो। मर्नु ठुलो कुरा होइन, तर उसले जीवन रहँदा के गर्छ त्यसको महत्त्व हुन्छ। So SSN dedicates this 1 hour of CME to the name of Professor Upendra Devkota, and I wish you a great presentation. Thank you, sir. Thank you all.
Thank you, sir. The legacy of Professor will continue to guide the Surgical Society of Nepal. Without further ado, I'd like to begin the proceedings for the monthly clinical meeting today. And I'd like to invite the first presenter, Dr. Ulla Burathoki, who is a first-year resident at PAS, to deliver his presentation on a retroperitoneal mass of dubious origin. Thank you.
Thank you, Dr. Andra. It's my pleasure to present a topic in Society of Surgeons Nepal today about a case of a retroperitoneal mass of dubious origin. This is a case of a 22 years old lady who presented in our surgical OPD with a complaint of abdominal mass of 3 months duration, which was gradual increase in size associated with mild left upper quadrant pain. Apart from that, there was no any other systemic complaints. There was no significant medical and surgical history as well. Regarding general examination, it was normal, it was well built, or vital, it was within normal range. On examination of abdominal lump, it was palpable, non-tender, occupying left hypochondrium around the size of 6 to 7 centimeter from left subcostal margin. On the upper pole was not appreciated and it was not mobile. And other systemic examination was within normal limit. Ultrasonograph shows large anechoic. Ultrasound shows large non-echoic mass near the left penis with the size of around 12 centimeter, extending from the left hypochondrial region up to the left supraumbilical region. CT scan shows the non-enhancing lesion in the post-contrast study with the size of around 11 centimeter in the left upper quadrant. The cyst was averting and displacing the pancreas anteriorly, as you can see here, averting the posterior wall of the stomach and averting the upper pole of left kidney. And fat planes were normal. CT features suggestive of large retroperitoneal cyst, suspicious of adrenal cyst, and the differential diagnosis was with adrenal pseudocyst. Lab investigations regarding CBC, RFP, LFT, they were normal. ELISA for echinococcal antibody was negative. Amylase was normal. Exploratory laparotomy, this large retroperitoneal mass was visualized after reflecting the omentum, stomach, cephalid, spleen laterally and colon downward. It was separated from the pancreas and splenic vein, and it was densely adhered to its nearby structure, which was dissected thoroughly. At the end of the dissection, a single draining vein was identified from this retroperitoneal mass, which was draining towards the left renal vein. As such, the vein was identified to be the left adrenal vein, and intraperitoneally we diagnosed this mass as the adrenal mass. It was excised in total and sent for the histopathological examination. And post-operatively, the recovery of the patient was uneventful, and as such, the patient was subsequently discharged on the 5th day. Finally, histopathological report shows that the cyst was composed of fibrous tissue without any epithelial lining. As you can see here, this is the fibrous tissue. And the final diagnosis was made of adrenal pseudocyst and negative for malignancy. With this case, with the final diagnosis of adrenal pseudocyst, I would like to discuss a few points regarding this adrenal pseudocyst. It is a rare lesion. The first reported case by Grace Ellis in 1670 in autopsy finding. Till now, there are 300 adrenal cysts, out of which less than 100 is found to be adrenal pseudocyst. Most of the time, usually it is adrenal pseudocysts are non-functional and asymptomatic. Epidemiologically, in the city, the frequency has been estimated around 0.35 to 4.4%. And in the age presentation, usually diagnosed during 5th and 6th decade, female ratio is more than male, 2:1. And pseudocyst comprises 39% of all adrenal cysts, and it is bilateral in around 8 to 10%. And the incidence of pseudocyst among cystic lesion of adrenal gland is 39%. And the etiology. Regarding etiology of this adrenal pseudocyst is debatable, but still there are certain theories. One theory suggests intra-adrenal hemorrhage because of trauma, sepsis, or any systemic insult. Or there could be due to malformation of artery or vein causing cystic dilatation and hemorrhage. And another theory suggests true cyst losing inner lining due to inflammation or bleeding. Clinical features of the adrenal pseudocyst, basically most of the time is asymptomatic, and incidentally it could be detected during imaging. Other features could be abdominal mass and acute abdomen due to intracystic rupture, hemorrhage and infection, and occasionally, very rarely, could be the adrenal hypofunctioning. Differential diagnosis could be splenic cyst, renal cyst, hepatic cyst, pancreatic pseudocyst, or solid adrenal tumor. And is there risk of malignancy? And there it has been suggested that the malignancy is 7% if size is more than 6 centimeter of this adenosudosis. And the investigation, ultrasound is the initial test. What is sensitivity is 66 to 90%. It cannot differentiate two cysts versus pseudocysts. CT scan is another modality for investigation, in which cyst is identified as a well-defined non-enhancing cyst on contrast study. Malignancy could be differentiated with a feature of thick, well-enhanced border, extension to the surrounding tissue, and indistinct margin. MRI is another modality which shows a solid component with low intensity on T1 and T2 weighted images with some smaller fluid components. Nuclear medicine is quite helpful to differentiate adrenal pseudocysts from pleochromocytoma. And the functionality tests are like 24-hour urinary metanephrine, 17 hydroxycorticosteroids, and 17 ketosteroids can be done. Though these investigations are required in all solid tumors, yet they are not mandatory in asymptomatic cystic lesions. If done, then they may prove beneficial. Regarding the treatment of this adrenal pseudocyst, it is suggested that surgical excision to be done if adrenal lesion is more than 5 cm, if malignancy is suspicious, if the functional adrenal cyst is rare, or in case of size less than 4 cm with suspicion of malignancy. For the size less than 4 cm, it is repeated on 3rd month, and the patient is followed up for at least 18 months. And there is another one case review in Greece where a 28-year-old woman was presented with an upper abdominal mass with 11 centimeter size, who went exploratory laboratory and found to be pseudocyst in histopathology. And similarly, in the study, the case in done in Atlanta, again the case of a 54-year female with she was also underwent the exploratory lab with found to be pseudocyst of around size 30 centimeter. And now to conclude my case, the adrenal pseudocyst is one of the rare lesions since it is asymptomatic and non-functional, and it could present the diagnostic dilemma. And imaging is not always conclusive and is confirmed by histopathology. And surgery is recommended if the size is more than 5 centimeters or suspicion of malignancy, as it has a malignancy potential of around 7%. Thank you.
Thank you, Olaf. Now I'd like to invite questions and comments from the floor.
I really congratulate your team. What was the nature of the fluid? Was it hemorrhagic or something else? And what were the cytological findings of the fluid inside?
The nature of the fluid was it was brownish thick fluid, and cytology was negative for malignancy. According to the literature, it says that for at least 18 months the patient should be followed up. For initial 3 months, for 4 months CT scan is done, and subsequently the patient is assessed clinically with a lab investigation and with the modality of ultrasound, and if need be, then CT scan should be done in the at least for 18 months follow-up. And after that, patient is not regularly followed up for around 6 months, 6 monthly, 8 monthly, and 9 monthly. Patient could be followed up. Or if the patient has any symptoms due to functional symptoms of functionality, and then patient could be followed up for later on. So 18 months पछि कति समय गर्ने भने there is no any fixed.
Thank you, Olaf. Now I'd like to call the second presenter, Dr. Patan Sikdel, to present on an unusual guest in gallbladder and intraoperative surprise. Thank you.
Thank you, Dr. Onra. Good morning, ladies and gentlemen. Today I will be presenting a case, unusual guest in a gallbladder and intraoperative surprise. So this is a case of 19 years old lady who reside in the urban area of Lalitpur, presented to ER with right upper abdominal pain for 3 months, which are aggravated for 2 days with no issue of fever, nausea, vomiting, and jaundice. She also had multiple ER visits with similar episode of abdomen, where USC was done and found to be a gallbladder cell, and she was managed then as biliary colic. On clinical examination, Murphy's sign was positive, and rest of the clinical examination was unremarkable. So with the initial acute calculus cholecystitis, we did some investigation, and investigation showed leukocytosis, liver function tests were within normal limit, and USC shows echogenic gallbladder cells with a polyp of size 0.8 centimeter. So with the diagnosis of acute calculus, we admitted the patient, managed her conservatively. She improved on treatment and was subsequently discharged from our hospital. And at discharge, she was planned for elective laparoscopic cholecystectomy after 6 weeks. During surgery, we encountered dense adhesion at the callot triangle, and surgery was non-progressing. Laparoscopic procedure had to be converted to open cholecystectomy. And on cut section of gallbladder, the gallbladder was thick-walled and contained clear bile, but there were no sludge, stones, or polyp. And to our surprise, there was single brownish leaf-like worm inside the gallbladder lumen, which was adherent to the mucosa. So this is the cut section of the gallbladder, in which we can appreciate a leaf-like worm structure in the gallbladder lumen. And on removing it from the gallbladder, it appeared like a leaf-like worm. This is the intraoperative video, which shows the worm in the gallbladder, and the worm was mobile. So on close inspection of the worm, we found it to be around 2 into 1 centimeter square, flat brownish leaf-like fluke with ventral and dorsal suckers, which was morphologically consistent with liver fluke. Our post-operative period was uneventful, and she was discharged on second post-operative day. Stool routine examination done was negative for any ova and parasite, and at follow-up on 8th post-operative day, patient is comfortable. Our repeat stool examination repeat no ova or parasite, and USC abdomen and pelvis done showed no features suspicious of fluke or worm in common bile duct. Our histopathological report of gallbladder was consistent with eosinophilic cholecystitis associated with liver fluke, and a flat worm histopathology slide was consistent with fasciola hepatica. So the histopathological slide I have taken from Canadian Medical Association Journal. In this, we can appreciate that these are the ventral sucker, and these are the dorsal suckers of the fasciola hepatica with a thick integument lining. And the histopathological report of our slide was also consistent with a similar finding. So in this, we can appreciate this structure as the ventral sucker, and this as the dorsal sucker, and there are thick spiked integumentary lining with branching intestine. And the histopathologically, this report is consistent with fasciola hepatica. So we made a final diagnosis of fasciolasis. So now briefly going through the topic, fasciolasis is a zoonotic disease which is caused by a tramadol fasciola gigantica or hepatica. This disease is globally distributed but highly prevalent in South America, in a country like Peru, Bolivia, and also in some part of Central Asia and Africa. When infected, it mainly inhabited liver, common hepatic and bile duct, but also the ectoparasitism in subcutaneous tissue, pancreas, stomach, colon have been reported in literature. So now briefly going to the cycle of the fasciola. Man is accidental host, and the mammal, including man, gets infected when they consume the infective metacercaria stage by consumption of aquatic vegetation, mainly watercress, and this fluke develops to the adult worm in the human, and the human passes the ova in the and the life cycle continues in the fresh water. So now when fish infected, either they present as an acute hepatic stage or in a chronic biliary phase. In case of acute hepatic phase, patient may clinically present at severe right upper quadrant pain associated with constitutional symptom of fever, weight loss, myalgia, and with absolute eosinophilia. Whereas in chronic phase, patient may present as jaundice, chronic cholecystitis, cholangitis, liver abscess, or recurrent biliary colic. So can we diagnose the case preoperatively? Given the rarity of the diagnosis of fasciolasis is often difficult and difficult preoperatively. Eosinophilia, though is a constant feature, is not diagnostic for the disease. Serological tests like ERASA have claimed to have sensitivity and specificity of more than 90%, but the limitation of these studies are that it is not easily available and are expensive. So the recommended investigation modalities for fasciolasis in acute phase is ELISA against cathepsin-based antibody, and in chronic phase, demonstration of parasite or ova in the stool or bile or duodenal aspirate. Now talking about the treatment option, the WHO has recommended tricarbendazole as a drug of choice for treating fasciolasis, which has expected cure rate of more than 90%, prescribed as a single dose 10 mg per kg, and the alternative medication are nitazoxamide, which has slightly lower cure rate as compared to tricarbendazole and has to be prescribed in a multiple dose for 7 days. Other treatment modalities include dry hydroimethine and phenol, but these are not practiced nowadays and are obsolete. Regular use anti-albendazole like albendazole, praziquantel are not effective against fasciolasis and those are not recommended for the treatment. So on the topic about the fasciola hepatica, Shah et al. Have claimed to report the first case of fasciola in Nepal in the year 45 years female who had presented with acute colitis, and evaluation with ERCP they found a flat worm resembling fasciola, and the stool routine examination revealed ova of fasciola hepatica. Similar case was reported from Iran by Dr. Tahir, in which the 28-year-old female who presented with acute cholecystitis was operated with a laparoscopic cholecystectomy, but the intraoperative found the worm which was swimming in a bile of gallbladder, and this worm was consistent with fasciola hepatica. And similar case was reported in the year 2007 from Turkey, in which the 48-year-old lady who underwent laparoscopic cholecystectomy for gallbladder, intraoperatively it was found to be adult type of living fluid in the gallbladder, which was confirmed as fasciola hepatica in a histological finding. So now concluding my presentation, biliary fasciolasis is a rare diagnosis and mostly come as a surprise to the surgeon intraoperatively. And in a patient with a recurrent biliary colic and with a peripheral eosinophilia, high degree of suspicion is warranted to diagnose the case of biliary fasciolasis, and drug of choice is tricarbendazole, and the other regular anti-emetic drugs like albendazole and praziquantel are not recommended for treatment of fasciolasis. Thank you.
Thank you, Bidan. If there are questions from the audience, on behalf of the tech support, I'd like to request you to please speak to the mic because other centers will also benefit from the discussion. Thank you.
Good morning. I am Dr. Vijay Sharma. If correctly I heard, you said gallbladder had a gas. Is it? No? Okay. Okay. So, this is a fish worm. Yeah?
Yes, sir. It's not fish worm.
Fasciola hepatica is a fish worm.
No, it's a liver fluid, sir.
Liver fluid, but it is transmitted through fish.
No, snails.
Snails, okay. Okay. And if you don't treat, what will happen?
It's not treated. So, if not treated, then the feature of obstruction may present as a cholangitis. Yes, sir. Sepsis.
Well, what happens depends upon where is the fasciola hepatica, obviously. Now, we did come across, I don't know if Dhana Karki is in the, here you are. We too were doing one, and recurrent colicky pain with cholangitis clinically. We did ECBD, and there was actually swimming, floating fasciola hepatica. It so happens that if you pull it out and put it in the saline, it seems to die immediately. And our patient also actually came from northeast part of Godavari, where he lives. He used to live anyway. Godavari. I just wonder whether your patient was also from that area, and we took the history. Did she take any, glass or something like that? She said while working in the field, she used to drink water, from that hill, running water. That's all we got it. But it is common in that area, it seems. Thank you.
Did you treat the patient with tricarbendazole, or is it available in Nepal, and how did you further go for treatment?
No, sir, we haven't treated him yet.
So, query, actually this patient is living at Imadol, sir. Imadol, and we retrospectively we asked about because this is transmitted through the aquatic plants and these things. So we asked, but she denied. Thank you, sir. And tricarbendazole is not available in our, and we asked for in our pharmacy also. It was not available. In other pharmacy also it is not available. Thank you, sir.
Yeah, it was the problem to us also. We also at that time could not find tricarbendazole, and it was finally brought from India, and we prescribed to the patient. One suggestion over you is that once you open the gallbladder, found fasciole hepatica, did you perform intraoperative cholangiogram? Because the site gallbladder is less than the site common bile duct. It would be better to have intraoperative cholangiogram because it's easy procedure, and to exclude biliary, common hepatic or common bile duct worms at the same time, because sometimes you can miss. It may be smaller, might not be symptomatic at that time, but anyhow, if you will get tricarbendazole, it's okay. But if not, then that might cause problem.
This is second time I think it's been presented in Surgical Society. Previously been presented as a CBD, it's cholangitis. You didn't mention about China. It's quite common in China, and this is the reason that why this is also known as Oriental hepatolithiasis, and they attribute this as a cause of this liver flux.
Thank you.
If there are any questions from other centers. Thank you. Thank you, Bidan. The next presenter is Dr. Vivek Gurung, who will be presenting on 46XY. He's the medical officer at PAS.
Good morning, ladies and gentlemen. I am Dr. Vivek Gurung, presenting on topic 46XY. This is a case of 24 years unmarried lady presented to us with bilateral, painless, irreducible inguinal swelling since childhood. She also gave history of primary amenorrhea till date, for which she has consulted Department of Gynecology and was referred for surgical causes regarding the swelling of inguinal region. On examination, she was well built with stable vitals at presentation. On local examination, there was bilateral inguinal swelling, which was firm, mobile, non-tender, irreducible, of size approximately 4 by 3 cm on right and 3 by 2 cm on left. So we revised for ultrasonography, which reveals heterogeneous oval soft tissue located in bilateral inguinal region, likely undescended testis. There was no evidence of uterus and adnexa, and for further evaluation, MRI was advised. But before that, we re-evaluated patient, which showed bilateral breast at cancer stage 2 with absence of body hair, armpit hair, pubic hair, and normal female genitalia with no clitoromegaly. On MRI, bilateral testis was present in inguinal region with right side slightly larger than left, and blind ending vagina with no evidence of uterus, proximal vagina, and ovary. Features was suggestive of complete testicular feminization syndrome. For furthermore, hormonal analysis was performed, which showed normal FSH level, raised luteinizing hormone level, and raised LH-FSH ratio, with slightly elevated estradiol and normal testosterone level elevated in respect to a female. And to rule out any chromosomal disorder, we tend for chromosomal analysis. And to our surprise, karyotype showed 46XY in a male chromosome in a phenotypically female individual, which was consistent with sex disorders such as sexual reversal disorders such as androgen insensitivity syndrome or gonadal dysgenesis. In risks of development of testicular carcinoma, since our patient has already achieved the age of puberty, we planned for bilateral orchidectomy and was performed. Intraoperatively, to rule out any urogenital sinus disorder, we performed cystoscopy, which was normal. Other operative findings were bilateral testis was present in superficial inguinal pouch with right testis larger than left and short blind-ending vagina. Post-operative period was uneventful and was discharged on second post-operative day. Our histopathological examination of the specimen showed seminiferous tubules with few germ cells and hyperplasia of Leydig cells. There was no evidence of intratubular malignancy or neoplasm, and with final diagnosis of complete androgen insensitivity syndrome. Now, moving on to this part of discussion. Androgen insensitivity syndrome, in its complete form, is a disorder of hormone resistance characterized by female phenotype in an individual with XY karyotype and testis producing age-appropriate normal androgen. And the incidence is one case in every 20,000 to 64,000 genetic males. It was first described by Morris as an inherited X-linked recessive disorder and condition that results in partial or complete inability of cells to respond to androgens. Regarding pathophysiology, there is testicular receptor mutation, which is coded by KR gene in X chromosome, and which results in androgen insensitivity and testicular feminizing syndrome, also known as androgen insensitivity syndrome. It occurs in three types. It might occur in a complete form, or partial, or mild one. In following conditions, we should suspect, are there any androgen receptor disorder? Male and females with ambiguous genitalia, girls with inguinal hernia, girls with bilateral inguinal hernia or labial swelling in nearly 2% has been diagnosed as complete androgen insensitivity syndrome. And women with primary amenorrhea, adolescent girls with virilization, and adolescent boys with failed puberty, and men under virilization with. These are the diagnostic criteria for complete androgen insensitivity syndrome. XY individual with testis along with normal female external genitalia, androgen receptor gene mutation, spontaneous feminization with primary amenorrhea, decrease or absence of pubertal axillary and pubic hair. Now, regarding the management, general treatment is based on correct diagnosis, early sex assignment, which is often difficult and complicated decision due to socio-economic implication. And individuals of CAIS, complete androgen insensitivity syndrome, are raised as females. And surgery, post-pubertal gonadectomy is performed. After that, estrogen replacement therapy with vaginal length dilatation, which is first-line therapy with very few requiring vaginoplasty, and psychological support. Regarding timing of gonadectomy, optimal timing is often debatable. Advantage of leaving testis till puberty allows pubertal change to happen naturally without any hormonal replacement, but at the risk of developing a testicular carcinoma, which is 2% in up to till puberty, and retaining testis, however, after puberty has significant rise in chance of developing benign tumors and 4 to 9% chance of developing malignancy. And to conclude, androgen insensitivity syndrome varies largely in phenotypic expression due to specific nature of mutation, and detection at birth and puberties allow more effective treatment, and parents, including those of newborns, children, adolescent, and adult patients should receive age-appropriate information regarding their gender and psychological support, and USG should be performed in all cases of female with bilateral inguinal hernia or labial swelling, as nearly 2% of those might have complete androgen insensitivity syndrome. That's all. Thank you.
Questions and comments from the floor?
Thank you for this rare case presentation. I just wonder, what did you do with this girl now? What was your future plan? How did you counsel?
After karyotyping, we talked to the patient regarding her gender, and we said that her makeup genotypically is of male, but since she has been brought as a female and she preferred to be a female, we performed orchidectomy, and we have planned for we have referred her for endocrinologist for hormonal replacement therapy, and she is quite happy with her gender being female, and she that's genotype.
Thank you for the excellent presentation. I think it was easy to decide in this case, as the lady was already 24 years old. But if the patient had been in her or his childhood, I think the gonadectomy would have been a difficult decision.
Yeah.
I remember a similar case in this institution, which was reported in one of the Journal of Society of Surgeons somewhere in 2008 or 9. And at the time, we found testes in the both inguinal canal, and we did orchidectomy. But from the human rights perspective, later on we did lots of literature search, and we found that it was not right for us to alert gender to our patient. We should not decide which gender they should be brought up. Actually, the human right, there are lots of issues regarding this from the human rights section, and they think that we should wait till the patient reaches her or his 18 years, and they should decide which gender they want. And I think the gonadectomy should wait until 18 years if they were found at the time of their childhood. But it was not the case in this case. The patient was already 24 years and she wanted to remain as female. Thank you.
Yes, in literature also they have parents are counseled, and the preference should be given to parents and the children, so that in adulthood they might prefer which gender they would choose. But in case of complete androgen insensitivity syndrome, they are raised as females, and they psychologically they become female. Such type of literature there are saying. So when in literature it has said that parents, it is the preference of parents to do early orchidectomy or late orchidectomy.
You said the optimal time of operation is debatable.
Yes,
everybody doesn't agree. To me, when you get undescended testis, you operate if it doesn't descend as early as possible, because the malignancy, chances of malignancy is there. Since he's already 24, probably he is in position to give consent which sex he wants to. So there is no need to ask parents, because he's already 24. Thank you.
We are not talking about orchidopexy. We are here talking about orchidectomy. Now, suppose this patient become a male, what would you do? So, there are so many factors which is very, very important. Lot of psychological counseling. You said, why ask the parents? In our society, a dubious genital patient with a dubious genitalia, they even might not have gone to school. They somehow cannot make their own decision, though they are 18 years old, they should be able to make the decision. Suppose because his testosterone was normal and he was, or this person was attracted to the female, what would you do? You can't do anything. You see, this patient needs a lot of psychological counseling, and it is so much easier to, even if she didn't have a vagina, suppose there was a shallow pocket, we could easily phalloplasty, I mean the bowel or small bowel, and I have got the experience. They, if you use that structure regularly, and they are quite happy. If you are considering now, because he wants to be male, in our society, everybody wants to have a male child. Okay, so there is a problem. You see, your phalloplasty will not be functional. Even to create urethroplasty will be impossible. I have had a case recently where there is a urethra opening into the anterior wall of the vagina. Now this is a otherwise male patient attracted towards the girl. The hair distribution is male. We decided to leave that part of the vagina alone. We are planning to bring the urethra up in the top, but trying to remove that vagina will complicate things. What does it matter? Let him be, with the small bit of vagina, but otherwise a male patient. Otherwise, to make a male patient is very, very difficult. To make a female patient, if somebody has got a male phallus, it is so easy. Actually, when you take the photograph, you will not be able to tell whether it is actually a male patient you are talking about or a female patient. Thank you.
Residence in pediatric surgery. So we also had similar cases, 2 or 3 of similar cases in Bangladesh. And what we did was they also opted, because the girl was 18 years old, and they opted for a female phallus. So and it is far easier to convert, not convert. They are actually raised as female, because since even though the testis is producing testosterone, the body is not going to the receptors are not active against testosterone. That is the problem there. So it is far easier to make a female out of that child than to make it a male. And regarding what Sir just said about that vagina and the urethra, sometimes we get such kind of problems when there is a very proximal variety of hypospedia. And in those cases, oftentimes we see that the prostatic utricle is quite enlarged and it appears like a blind ending vagina. So in those cases, what we do is we usually go for a male phallus. So that can be slightly helpful there.
This case was relatively easy to manage. She presented late, and also because of the fact that this was a case of complete androgen insensitivity. Unlike other causes of ambiguous genitalia like congenital adrenal hyperplasia, gonadal dysgenesis, mixed gonadal dysgenesis. So physiologically, in these patients, the male gonad would be making male hormones, which gets aromatized to estradiol. So so the male gonad should not be removed until the age of 18 or 16. Until the age of 18, physiologically. There has not been a single case report as of yet where a girl, a phenotypic girl, has asked to be converted to a female. So management in this case is relatively easy as compared to cases of other like mixed gonadal dysgenesis.
Thank you, Vivek. Now I'd call upon Dr. Hariya Radhikari to present a difficult urethral injury.
Good morning, ladies and gentlemen. I'll be presenting on a topic on difficult urethral injury. 29-year-old gentleman who had RTA 5 months back sustained bilateral pubic rami fracture, superior and inferior, with left acetabular fracture with urethral injury, for which access he was free. On retrograde urethrography, we could see the contrast medium up to the bulbar urethra. On micturating cystourethrophy, you could see contrast medium up to the level approximately the posterior urethra. So altogether this was a defect. And for progressive perineal urethroplasty. During the surgery, bulbar urethra was circumferentially mobilized up to the level of tenospral junction and the defect was transected. However, anteriorly passed sound could not be palpated even through crural separation, generous inferior pubectomy, and proximal urethra could not be identified even after Ozeni's technique. Hence, transpubic approach via lower midline laparotomy was considered and done. Osteotomy was done, and a wedge of superior part of pubic bone, approximately 2.5 centimeters, was excised. Proximal urethra was identified by passing a sound through a longitudinal cystoscopy. Bulbar urethra was then brought into the abdomen through the subpubic tunnel. This beam of light over here shows the subpubic tunnel, and these are the urethrae before anastomosis. A tension-free urethral anastomosis was created by 6 clear-vical sutures. An omentum pedicle was wrapped around the site of the anastomosis and intrapelvic segment of the bulbar urethra, the sole patch. This is the perineal view after the completion of the anastomosis. His post-operative period was uneventful, and after 4 weeks, pericatheter urethrography was done, which didn't show any leakage, so the catheter was removed. And after catheter removal, he had good urine flow. On follow-up, the patient had good urine flow, and the urethrogram was done after 3 months of surgery, which was normal, without features of urethral stricture. On discussion, pelvic fracture urethral injury is the injury at the bulbar membrane junction, usually a distraction defect. Bladder and prostate are displaced upwards and posteriorly, and sometimes anteriorly and laterally. The definitive management of this condition is delayed anastomotic urethroplasty. A minimum waiting period of 3 to 6 months is mandatory. The principle of anastomotic urethroplasty in this case is complete scar excision, tension-free anastomosis, mucosa to mucosa apposition. These three together comprises the golden triad. The main issue that we encountered in this surgery is the anastomotic tension. The reason behind this are, first of all, the defect has to be excised, and for anastomosis we have to spatulate 1 centimeter of urethral defect. So a defect of 2 centimeter becomes approximately 4 centimeter. Besides that, the bulbar urethra is on the fused corpora and the pubic bone. This is the natural position of the bulbar urethra, which is roughly semicircular. And if we have to reduce tension, we can reduce the distance between them by this in this way. By doing this, we can gain a distance. We can reduce the tension between the two defects and gain a distance approximately the difference between the semicircumference of this circle and the diameter. For reducing tension, Weston popularized transperineal progression approach. This approach comprises of 1 or more of 4 maneuvers done sequentially. The bulbar urethral mobilization as shown in this figure. Second is the corporal body separation. Third is inferior pubectomy. And fourth is the suprapubic rerouting of the mobilized urethra as seen in this figure. However, can we predict the steps required in an index office? The answer is no. The reason behind that is preoperative radiogram doesn't always reveal the posterior urethra. The length of the defect seen in preoperative radiograms may not correlate with the type of surgery. So when it is insufficient by the use of those steps to visualize the proximal urethra, we opt for transpubic urethroplasty. Which indications are when posterior urethra cannot be identified, when there are complicating factors like paraurethral bladder fistula, rectal urethral fistula, bladder neck injury, urinova cavity, when the defect is greater than 2.5 centimeters, when the length of defect is greater than 1/3 the length of bulbar urethra, and sometimes in children. The advantages offered by this approach are it provides wide and excellent exposure. Anastomosis can be done under vision. It allows correction of complicating factors, and it allows the use of momentum. Case report. A case report by Kotaim shows that this approach is successful in 98% patients, and he concluded that transpubic approach provides an excellent exposure and greatly facilitates the creation of an under-vision tension-free and scar-free bulboprostatic urethral anastomosis. Another study done in AIMS showed that this procedure had excellent outcomes in 84% of cases, and they concluded that transpubic urethroplasty is an excellent approach for patients with complex urethral strictures. On conclusion, transpubic urethroplasty should be considered when perineal approach doesn't provide comfortable access to the proximal urethra. A surgeon doing this surgery for pelvic fracture urethral injury should be conversant with all the steps of progressive perineal approach and the transpubic approach. Thank you.
Thank you. The floor is now open for questions.
Was it really a transpubic approach, or did you only take the bit of the inferior ramus of the pubic bone?
First, we approach perineally. The third step of reducing tension perineally is to do inferior pubectomy. So I did inferior pubectomy, excised a huge chunk of bone. That's not transpubic. After that, I didn't do a supraocular rerouting. I rather did a laparotomy and
because your evidence-based presentation was good, but when there is a distraction of the urethra with following the fracture of the pelvis, it is really very, very difficult to treat. So that's why I started doing early endoscopic realignment, which has been, of course, condemned by many. Now they are coming back again. No, endoscopic realignment at least will make the definitive surgery much easier. Maybe, I am not sure. I have the longest series of early endoscopic alignment, which is more than 60-70 cases. Now, at least if you think self-catheterization is not, appropriate, you should them and give them as far as possible normal urethra. Then at least if you do the endoscopic early alignment, your definitive surgery will be much, much easier. Thank you.
Thank you, Arya. Now, the penultimate presentation of a rare case of rectal bleeding by Dr. Nischal Shrestha.
Hello. Good morning, ladies and gentlemen. I'd like to present a rare case of rectal bleeding. An 18-year-old gentleman presented to us 1 year. Bowel weight loss, anorexia, pain, and he had no family history of colon cancer. He had previously sought at multiple centers and gone an endoscopy and sigmoid polyps. His histopathology reported of multiple juvenile polyps, and his upper GI endoscopy and CA levels were normal, and he was planned for a low anterior resection at other centers. So the patient came to us seeking second opinion. Physical examination, his per abdominal examination was unremarkable, and on a digital rectal examination, rectal polypoid growth 4 cm from the anal verge was. The gloved finger was not stained with blood. So we planned for a CCT abdomen and pelvis to look for the extent of the disease. The lesion was localized to the rectum, and there was normal perirectal and mesorectal, and there was anal and distal abdominal neuropathy. So we did a sigmoidoscopy. We can see in this picture
the lower rectum which started with multiple polyps. The upper rectum was normal and there was a single polyp in the sigmoid colon. So with this sigmoidoscopy finding, we planned for polypectomy through multiple sessions due to the sheer number of polyps. The patient underwent examination under and polypectomy. We can see the intraoperative pictures. This is the rectum being retracted downwards. Polypectomy was carried out 10 centimeters from the anal bulge, and the polyps were excised and sent for histopathology. The histopathology report came, and to our surprise, reported of cap polyposis. The histopathology picture shown in left shows a fibrinopurulent exudate covering the mucosa of the polyp, and in the right we can see the glands. So with this microscopic diagnosis, we again did a review sigmoidoscopy after 2 weeks, and in the two pictures above we can see that the polyps in the lower rectum have markedly decreased in number and size, and the single polyp present in the sigmoid colon pectomy. We again did a third sigmoidoscopy after 3 months. After 3 months, we can see multiple polyps in the lower rectum, whereas the sigmoid colon was normal. So with this sigmoidoscopy finding, we again planned for a second session of polypectomy, and in this session, we planned for a transanal minimal surgery, TAMIS. The patient underwent TAMIS. In these pictures, intraoperative pictures, we can see the gel point path being inserted. After the gel point path had been inserted, pneumorectum was created and the laparoscopic instruments were introduced. This is the intraoperative video showing laparoscopic resection of the polyps. After the polyps were resected, the port was removed and the side polyps were also removed. The patient was then discharged on post-operative day 1 with stool softeners, and our plan is to review the patient after 3 months with a sigmoidoscopy. So talking about this, cap polyposis is a rare disorder which was first described by Williams in 1985, and approximately only 60 cases as case series or reports have been reported in medical literature. The exact incidence of this condition usually occurs in the 5th decade of life, and the cases have been reported both in men and women, ranging from ages of 12 to 76. The exact etiology and pathogenesis of this condition is unknown. It has been hypothesized that it is to abnormality, and there have been some also. The patients with this might be asymptomatic, the most common symptoms being diarrhea. Others include abdominal tennis, and condition has characteristic endoscopic finding. Endoscopy, we can find polyps covered with fibrinopurulent edge. The number of range from a size might range from few millimeters up to 7 centimeters. The polyps are usually located at the apices of mucosal, and the intervening mucosa between the polyps are normal. The morphology of the polyps is ulcerative or flat type, and the polyps are usually present in the rectum or the rectosigmoid, but there have been reports of polyp pancolic involvement as well as gastric involvement. So with this endoscopic finding, this condition might mimic other colonic diseases also, but the definitive diagnosis of this condition is made on histology. It has characteristic histologic findings. We can see that there is ulceration of the polyp mucosa with a fibrinopurulent exudate on top of the ulcer, which has likened to be of a cap, so hence the name cap polyposis. And there might be hyperplastic gland. So the same histology picture was seen in our patient's histology examination, so we made a diagnosis of cap polyposis. Regarding the management of this condition, there is no specific treatment. Asymptomatic treatment, and the goal is to improve clinical symptoms. In literature, there have been use of aminosalicylates, anti-inflammatory agents, example topical and systemic steroids, antibiotics like metronidazole, and immunomodulators like infliximab. But the evidence regarding their use is conflicting, and there have even been anecdotal reports of cap polyposis being cured by H. pylori eradication from Japan. They have reported endoscopic and symptomatic resolution of symptoms after use of H. pylori eradication therapy. Apart from medical treatment, other modalities include endoscopic polypectomy, and it has been associated with complete resolution of symptoms. It might be done by snare polypectomy, argon plasma coagulation, endoscopic mucosal resection. Patients with multiple polyps might have recurrence, so it is recommended that they undergo colonoscopy, review colonoscopy to see the persistence and the progression of the disease. However, the duration of interval of colonoscopy has to be individualized based on the adequacy of resection, the number of polyps, and the presence of symptoms. Apart from endoscopic polypectomy, surgery is reserved for patients with multiple polyps where endoscopic resection is not possible, and operation depends on the severity and distribution of colorectal polyps. Talking about the prognosis of the condition, natural history of this disease is limited due to small case series with limited follow-up. Up to now, there have been no reports of malignant transformation, and most patients have chronic recurrent symptoms and require multiple treatment modalities. So I'd like to wrap up my presentation with the message that cap polyposis is a rare cause of rectal bleeding. Misdiagnosis can lead in prolonged and inappropriate treatment, and transanal minimally invasive surgery is a useful modality in resection of rectal polyps, which are difficult to access through proctoscopy and stair polypectomy. Thank you.
Questions from the floor? Thank you, Nisha. Last but not the least, I'd like to call Dr. Yugal, our first year resident, to present on saving nephrons in a patient with RCC. Thank you.
Good morning, ladies and gentlemen. I'll be presenting on saving nephrons in a patient with RCC. Sorry for the delay. A 37 years old male who had hypertension for 4 years presented to us with right upper abdominal pains in 2 weeks, and he had family history of diabetes mellitus. And his ultrasound abdomen and pelvis was done, which showed solid round nodular mass of 4 centimeters in right hilar region with regular margin. There was vascularity at periphery with minimal caliectasis. And then his lab showed his urine routine microscopic examination was normal, serum creatinine was normal, and hematocrit was 45%. And then contrast enhanced CT scan was advised, which showed well-defined enhancing lesion about 4 centimeters in medial aspect of interpolar region of right kidney. The lesion was abutting the renal pelvis, and the renal vessels encased by the lesion. And there was no perilesional stranding, renal vein and IVC was normal, and there was no features of lymphadenopathy. So with this finding, our obvious management plan would be to perform a laparoscopic radical nephrectomy. But as the patient had history of hypertension and he had family history of diabetes, we thought of preserving nephrons as much as possible. So we ordered for a CT renal angiogram. And CT renal angiogram showed that posterior division and segmental branches of right renal artery were abutted by the mass lesion, and there was no evidence of luminal infiltration. So we planned for open partial nephrectomy under cold ischemia. And for preoperative investigations were normal for staging and for paraneoplastic syndrome. And we approached the patient with a flank incision, excising the 12th rib. The kidney was fully mobilized, preserving the perinephric fat overlying the tumor. The renal vein and artery were dissected and then fluid infusion was done to hydrate the patient, and mannitol administration was done prior to clamping of the renal artery and vein. And then kidney was covered with ice slush for 20 minutes to achieve a cold ischemia time of 27 minutes. And then tumor was excised with sharp and blunt dissection. Renal sinus fat overlying the hilar surface of the tumor was completely excised. The bleeding vessels were sutured. The rhinography was done using Vical using hemolock clip to secure the knot. This here picture shows the remnant kidney. And these are the pictures showing the specimen with overlying perinephric fat and renal sinus fat with normal renal parenchyma. Now regarding post-operative period, patient had adequate urine output. There was hematocrit drop by 6%. The patient developed superficial surgical site infection, and he was discharged post-operative day. This shows the pattern of serum creatinine after the surgery. On the day of surgery, his creatinine level was 1.1. However, it rose to 1.6 on first post-operative day, and then after it gradually decreased, and his latest serum creatinine levels 2 months after the surgery is 0.9. The histopathological report came out to be clear cell renal cell carcinoma with Perham nuclear grade 2, and the surgical resection margins were free of tumor, and there were no perineural or lymphovascular invasion, and there were patchy areas of necrosis present, and the pathological size was 4 by 3 centimeters, and the pathological rating of PT1 was given. Now coming to discussion, most of the kidneys these days are discovered incidentally at an early stage owing to the widespread use of cross-sectional imaging. And the Q1 tumor, they constitute about 60 to 70% of all the RCCs discovered. And traditionally, renal cell carcinoma, including small renal masses, have been treated with radical nephrectomy, but this past decade has seen a paradigm shift in the management of RCC, with emphasis on preserving the nephrons due to the awareness of predisposition to CKD and associated increased cardiovascular events and mortality after radical nephrectomy. And this statement has been highlighted by a landmark study that was done by Huang et al. In a Memorial Sloan Kettering Cancer Center in New York, where 662 patients were studied with normal creatinine and bilateral healthy kidneys. And these patients were to undergo either elective partial nephrectomy or radical nephrectomy for tumors, for renal cortical tumors less than 4 centimeters. And this study highlights even though patient had normal creatinine and 2 healthy kidneys, 20%, that is 1/4 of the patients had grade 3 CKD prior to the surgery. And the study, the results showed that after radical nephrectomy, 65% of the patients developed grade 3 CKD, and 35% of the patients undergoing partial nephrectomy developed grade 3 CKD, and 36% of the patients undergoing radical nephrectomy developed grade 3B CKD, meaning estimated GFR less than 45, whereas only 5% of the patients undergoing partial nephrectomy developed grade 3 CKD. And 3-year and 5-year probabilities of freedom from new onset grade 3 CKD was 80 and 75% respectively for partial nephrectomy, and 35 and 23% respectively for radical nephrectomy. So this study, radical nephrectomy is a significant risk factor for development of CKD and might no longer be regarded as a gold standard treatment for small renal cortical tumors. And other studies have also shown that partial nephrectomy for localized RCC is equivalent in terms of oncological outcomes as compared to radical nephrectomy. And with the introduction of laparoscopic surgery, as it is appealing to both the surgeons and patients alike, laparoscopic radical nephrectomy is being overused even for the small renal masses. But due to, in the recent years, due to increasing expertise in laparoscopic and robotic surgeries, more and more partial nephrectomies are being done laparoscopically and robotically, with equivalent oncological efficacy, margin status, and safety in relation to surgery. Now, European Association of Urology has recently updated its guidelines, and it states that the oncological outcomes in terms of disease-specific survival following partial nephrectomy equals to that of a radical approach in a patient with clinical or pathological T1 renal cell carcinoma with 1B level of evidence. And it is advised to offer partial nephrectomy to patients with Q1 tumors with strong strength of recommendation. And partial nephrectomy, be it in form of open or pure laparoscopic or robot-assisted approach, should be prescribed should be offered to the patient based on surgeon's expertise and skills. This has a level of evidence of 2B. It is advised not to perform minimally invasive radical nephrectomy in patients with Q1 tumors for whom partial nephrectomy is feasible by any approach, including open partial nephrectomy, being the strong strength of recommendation. So, as the renal parenchymal quality of a patient cannot be changed, so what factors that affect the renal function after partial nephrectomy? They can be either number of preserved nephrons or the ischemic interval. The nephrons can be preserved by precise excision of the tumor with small rim of normal parenchyma and by careful reconstruction to minimize the devascularization. And for ischemic and to minimize the ischemic injury, it is advised to keep the warm ischemia time to less than 25 minutes and cold ischemia time to less than 45 minutes, more preferably less than 35 minutes. So to obtain a core temperature of 20 degrees centigrade, the kidney should be covered with ice slush for 15 to 20 minutes after clamping of the pedicle. And adequate hydration of the patient should be done. And manual infusion 15 minutes prior to the pedicle clamping should be done. And there are various alternatives to pedicle clamping known as off-clamp techniques. This can be done by manually compressing the tumor or using hypotensive anesthesia or using various clamps like Libertino clamp, Kaufman clamp or Satinsky clamp. And other options of pedicle clamping, besides clamping both artery and vein, is artery-only clamping, selective arterial clamping, or clamping the segmental artery, and intermittent clamping, which is known as ischemic preconditioning. However, it is not advised in renal surgery. So there are few relative contraindications to partial nephrectomy. It can be broadly categorized as technical issues and cancer-related issues. For technical issues, if the cold ischemia time of less than 45 minutes cannot be achieved, then it is of relative contraindication. And if less than 20% of the global nephron mass can only be retained, then indication. And for cancer-related issues, if there is diffuse encasement of renal pedicle by the tumor, or diffuse invasion of central collecting system, or tumor thrombus has involved the major renal veins, or there is adjacent organ invasion or regional lymphadenopathy, then these are contraindications. So concluding my presentation, partial nephrectomy should be considered whenever feasible in a patient with RCC, and it is advised to repeat a CT scan, 3D reconstruction, or CT renal angiogram if partial nephrectomy is being planned. Thank you.
Questions from the audience? Thank you, Yuga.
You said the operation. You said the margins are okay. Do you have any provision of saying it appropriately whether the margin is okay or you wait? Margins are tumor. Yeah. Did you do frozen section or did you do?
No, sir, we didn't do frozen section.
How can you say that margin is okay appropriately? If the margins are positive, then what would you do next?
I understand what you're trying to ask. You're trying to ask whether we did a frozen section or not. So we don't have a frozen section, and we didn't do a frozen section. So we just based the completion of our surgery on our visual, what we saw intraoperatively. Regarding the significance of positive surgical margin. So when we do a frozen section, we don't do frozen section from the tumor bed, but we do frozen section from the margin of the specimen which we retrieve. So the significance of the positive surgical margin from the specimen which we have retrieved is that there is no difference in the tumor recurrence rate or the incidence of distant metastasis in patients with negative frozen section and positive frozen section. So there is only very slight risk of distant, 1 to 2% risk of distant metastasis. So in one of the largest studies which was published in BJUI regarding the significance of positive surgical margin after partial nephrectomy, what they said was positive surgical margin doesn't correlate with presence of residual tumor in the specimen. So if you have a patient with positive surgical margin, and if you do a radical nephrectomy, completion radical nephrectomy in the same instance, not a single individual was found to have tumor in the specimen. So it's interesting why a positive surgical margin doesn't correlate with the presence of residual tumor in the specimen. Hence, the significance of positive surgical margin is not as much as we think.
Yes, I agree, because there are a lot of studies also. If you have a positive margin, you don't go for a radical surgery. You wait, right? And then the the histopathology report. Nowadays, I think more of a WHO scoring is done rather than forum scoring. Do you have any? Did you talk with the pathologist?
Yeah, I'm Dr. Bozras from GE Teaching Hospital. So, this frozen section during partial nephrectomy is not mandatory. If it is available, well to use. So, if you do not have the facility of frozen section, you should not deprive the patient from partial nephrectomy. That is clear. Second thing is that positive margin. Now, recent recommendation is that the forearm of WHO has slightly differentiated because the nucleoli things or those things has been changed now. If that's of high grade, grade 4 or something like that, or something like sarcomatoid variant, something like there, then better to go for completion radical nephrectomy. Otherwise, easily we can observe, like the literature also supports for that. Now, forearms grading, now WHO ISOP has slightly changed in 2018, now practically started, and this pathological aspect has been completed by 2016 already. And there they have simplified. concept is same. Higher the grade, worse is the prognosis. They have mentioned about just nucleoli is present or absent for grade 1. Characteristic of the nucleoli they have omitted. That is there in 2018 now. But practically, WHO ISOP that has been recommended. Thank you very much.
Should be done whenever it is possible.
Bench dissection and auto transplantation up to that level is there now.
Yes.
Imperative indications or desperate indications, solitary kidney is there. If your patient is becoming anaphoric by removing that, take out the kidney to the bench, do bench dissection and transplant, autologous transplantation. That is there. Thank you very much.
That concludes the last and final presentation for today. I'd like to thank the presenters for their presentation as well as the audience for the lively discussion as well as your time. Now I'd like to yield the floor to the Executive Committee of SSN.
Thank you, Anurag. Thank you for Dr. Sanjay and the team, surgical team, for a wonderful presentation. You have good preparation, I guess. Thank you very much, and for the audience who are present here. I'd like to make a few announcements regarding the forthcoming International Conference of Society of Surgeons. The theme is Inserting the Safe Surgical Practice, and the date is November 29, 30, and December 1. The venue is Hotel Annapurna, and the registration for the members is 8,000 and non-members 10,000, and for residents it's 5,000. So I guess you have your membership taken for the benefit of the registration charges. The posters are already made, and the organizing committee has been formed. And one important thing is that the next executive committee election is going to happen in month of Bhadra 30. So interested the members and the who has got the enthusiasm to serve in the society are most welcome, and the notice will be published in a few days in paper as well. The websites and the journals are functioning, and I request you to go through the websites and the journal as well, and I request you to for the abstracts for the conference. And I thank you, DZPL, for this, as always, the sponsoring the IT. And I request President of SSN, Professor Sil Butterson, for his final remark. Thank you. Thank you all.
Good morning. It's really very interesting thing, that all you have presented very rare cases anyway. Anyway, we come to know about it. But before that, I would like to, my personal, I would like to give my, some kind of, I know that Rupesh Mukhi has already told about it, today there some kind of, Shok Sabha or something. But personally, because of the fact for the last 20 years, I have been knowing, I knew Professor Devkota very well, because there's some kind of, the relation we brought it up. You see that many years ago, when he was a small child, his father was that Kaviraj. So he was posted in a Baglung in a Kaviraj, as a doctor. And their family and my family, where I was studying in Baglung, they had a good relation. So that's the way how we grew up, that we just came to know each other very well. Not as a southern or something like that. And what I would like to say that we have already told everything about by Devkota. I just simply would like to say that, just a small that he was no doubt about it. He was a very able neurosurgeon. And I remember him very well, and he has contributed, as you have already said. So simply my, this Divangat Atma ko lagi Santi raha whatever, like mere condolence, sana purane, mere personal jane, mere tane purana chahanchu. Now let's talk about, today's meeting. You see that I was really very, I thoroughly enjoyed, having heard so many, rare cases, that you all have presented very well, no doubt about it. I think the first case, retroperitoneal mass of dubious origin. I think, it seems, that now you presented, the adrenal pseudocyst, but we are very familiar of knowing about pseudocyst. Most like the common thing is a pancreatic pseudocyst. This is what I was thinking, when you were presenting the case or something like that. But even then, it seems, that any organ in the abdomen or anything like that, or posterior wall, or posterior abdomen area, or anterior abdomen, anywhere, because we remember very well, the abdomen is a, the magic box or something like that. And you can have any kind of thing in there. So it is you have done very good job anyway. That's a very interesting thing. And another one of the unnatural gases. This is the one that reminds me, that I went to present to Hong Kong, a case of, that hydrodesis, daughter seed causing to obstructive jaundice. And those days, that didn't have very much about CT scan and this and that. That simply ultrasound had started and simply X-ray something. It was very difficult to diagnose whether it was a tumor or something. It was very difficult anyway. So I explored and I found that it was a daughter cyst of hydrodesis. And that I presented. And that time, there was a doctor from China. I said already that it's very common, the liver flux in China or something. He presented a series of, the liver causing the obstructive jaundice. So they found it out. This, that liver flux causing obstructive jaundice in the common bile. So we have to be very careful about it. Probably those people who come from, I know very well Nepal. We have got quite a lot of hydrodesis in the Mustang district, and I have been dealing with it quite a lot. And I have found it, but I never found it out. That the liver flux, but I found it a hydrodesis, daughter cyst. Now the third, the 46 XY. I think, that whatever you have done very good job, well done. But the most important thing, I agree with my colleagues what they said, I think this patient will need quite a lot of psychological support or something like that. Otherwise, he or she will have a very difficult time to have a normal life. And a difficult urethral injury, as you know very well, and urologists have already discussed about it. And I think you have done quite a good job, for the patient with a complicated urethral injury or something. You have done a very good job. You have given a good relief. And thank you very much, and well done. The rare rectal, the case of rectal bleeding, I have never heard about capsule polyp or something. We have heard about so many different kind of polyp, but a capsule polyp, I have never seen any patient. Probably I might have missed, I don't know. But I think you've done very good job. But the problem is, you see that the bleeding polyrectum is a really quite a difficult case sometimes, very difficult to diagnose. I think, that what you have done a wonderful job, and I'm pretty sure that the patient is benefited. So we know different kind of treatment of capsule polyps or something. The last one, you see that, is it a neurosurgeon, it is a nephrologist or something, it is a urologist who are treating this sort of disease or something. We used to read, and we used to have, also I work in urology, and they are talking about nephron sparing nephrectomy or something. Now you are talking about even for carcinoma, the renal cell carcinoma of the kidney. So what happens about radical nephrectomy? Is going to be out of picture or something like that? I don't know. Is the history of past or something? Because in a patient who has got a cancer renal cell carcinoma, patient will have to have a radical nephrectomy to give a good cure or something like that. But now you are talking about nephron sparing nephrectomy. Anyway, thank you very much. I have really thoroughly enjoyed, and I hope that that we will have interesting that, and all I request, and as already our secretary has already told you, we're going to have the international conference. I hope you all present very nice cases. We are going to have different part of the world, all southern coming to Nepal, and I hope that it will be enjoyable, and we are looking forward to it. Anyway, thank you for that Devrali Janta is always providing us anyway the very nice breakfast or something like that. So anyway, thank you.